Sharaya. I'm a PhD student at the University of South Australia. I'm currently in my second year. So today I'm just going to talk you through some of the results of our trial investigating the effects of intermittent compared to continuous energy restriction in people with type 2 diabetes. I'm going to show you our published 3-month pilot trial data, as well as talk you through some of the preliminary results for the 12-month data and some future directions where we're heading to next. So, as you are all aware, overweight and obesity does contribute to the development of type 2 diabetes, with approximately 90% of this population are overweight or obese. Weight loss improves glycemic control with as little as 5 to 10% weight loss, but we all know weight loss is very difficult. So the most common form of weight loss, or the most common method used, is what we call continuous energy restriction. This is just a usual daily diet, a moderate energy restriction of approximately 25%. More recently, there has been a lot of interest in, or focus of interest on intermittent energy restriction, which is an alternative method for weight loss. We call that IER for short. So IER is defined as short periods of severe energy restriction, such as 75%, interspersed with habitual eating. IER is an effective method for achieving weight loss comparable to CER in the overweight and obese populations, but there are no trials demonstrating its effectiveness in people with type 2 diabetes. So if you look at the research using very low calorie diets, there is plenty of research papers using very low calorie diets within a continuous energy restriction and then compared to a continuous energy restriction alone. And they do achieve significantly better results, of course, because they have a significantly greater energy reduction. So if we have a look at the results here, the CER with VLCD in blue, significant reductions in hemoglobin A1C and weight loss as compared to CER alone. But that doesn't really answer the question, can short periods of severe energy restriction within a habitual diet cause similar improvements to glycemic control and weight loss as CER in people with type 2 diabetes? So that's what I'm investigating. I want to determine if an IER 2 very low energy days with 5 days of habitual eating per week will create similar results for both change in hemoglobin A1C and weight loss. So we hypothesised that because the weekly energy consumption is quite similar, that there would be similar results for both of these outcome methods. So you can see here the CER diet has an approximate 25% energy restriction every day, and the IER diet a 75% energy restriction twice a week, and by the end of the week the energy consumption is very similar. So to talk you through the methodology of the pilot trial, the basic inclusion criteria is obviously people with type 2 diabetes, blood pressure less than 160/100, BMI greater than 27, and no history of weight loss surgery. Participants were then screened and then randomised according to BMI, allocated 1 by 1 to treatment groups. So the IER group followed a severe energy restriction of 500 to 600 kcals for 2 days a week. And this was approximately 50 grams of protein. Of course, it was low carb, and continued their usual diet for the other 5 days. The CER group followed a moderate energy restriction of 1200 to 1500 kcals a day, which was approximately 45% carbohydrate. All participants were provided with serve advice for each of the food groups, so 5 serves of vegetables, 2 serves of fruit, etc., and sample meal plans, and meal replacement products weren't used, and no food products were provided. Sensible eating was encouraged with approximately 2 to 3 discretionary food choices per week. So, as you're all wondering, what sort of foods do we use in the intermittent diet? Well, here we have the 500 kcal diet and some examples of food choices. So for breakfast, someone might have a serve of yogurt and a serve of fruit. And then for lunch, chicken salad with no-fat dressing, and then for dinner some white poached fish with some low-starch vegetables and plenty of water or herbal tea. And then if you look at the 600 kcal diet, the only difference here is the addition of a 1 breads and cereal serve, and so, for example, a slice of bread. The participants were asked to record their fasting blood glucose levels daily with 2 extra readings on IER days for safety reasons. Participants attended the clinic fortnightly for the first 3 months and then every 6 to 8 weeks for the final 9 months. And the same dietitian provided all dietary advice at all clinic visits. Compliance was monitored by reviewing diet checklists, weight loss, as well as blood glucose improvements or control. So our primary outcome measure for the trial was change to hemoglobin A1C, and that was measured at 3 months and at 12 months, and then again at 24 months, which was 12 months after the intervention was complete to look at maintenance. The secondary outcome measures include weight loss, body composition change measured by DEXA, blood results at fasting blood glucose and fasting blood lipids, medication effect score, which Grant described very well, which we used to monitor medication reductions. We looked at appetite via VAS, and finally recorded steps using a pedometer. So last year we published the results of the 3-month pilot trial in diabetes research and clinical practice, and we'll just have a look at those results now. In a moment. This is the participation and recruitment flowchart. So you see we had 84 participants screened for eligibility, 21 were excluded due to not meeting criteria or declining to participate, 63 were randomised, 31 to the IER group and 32 to the CER group. Dropouts were similar in both groups with a small 19% dropout rate, and so 51 participants were analysed at 3 months, 26 in the IER group and 25 in the CER group. And so as we expected, the diets did achieve similar results. So IER in the form of a 2-day very low energy diet and 5 days of habitual eating, essentially the 5-2 diet, was as effective as CER at improving glycaemic control and weight loss in people with type 2 diabetes. If we look at the results in a little bit more detail now, here you can see the reduction in hemoglobin A1C was decreased significantly over time, but not by treatment. CER is represented by a blue line, IER by the red line, and it was about a 0.8 reduction in the CER group and a 0.6% reduction in the IER group. Fasting plasma glucose is also decreased significantly over time, but not by treatment. The strongest predictor for hemoglobin A1C change was in fact baseline levels. So with a higher baseline, hemoglobin A1C was associated with a greater reduction. So we could suggest that the slightly greater reduction noted in the CER group is because their hemoglobin A1C at baseline was slightly higher, although it was not significant. So medication effect score was used to measure overall utilisation of oral hypoglycemic agents and insulin, and therefore to measure medication reduction during our trial. Medications likely to cause hypoglycemia, like sulfonylureas or insulin, were reduced or discontinued at baseline in the IER group, depending on hemoglobin A1C, and I'll chat you through how we did that in a moment. Metformin remained unchanged. So just a little bit of information about MES here. So MES is calculated using the participant's actual dose of medication divided by a maximum dose times by an adjustment factor, and that adjustment factor is how much the drug might reduce hemoglobin A1C. So if you look at diamicron, for example, let's say the participant had 60 milligrams of diamicron, you would divide that by 120 and times by 1.5. So if we look at the overall results of MES for this pilot trial, it did decrease significantly over time, but not by treatment. There was insulin reductions were greater in the IER group, and that did approach statistical significance. I also wanted to do a little bit of cost comparison and have a look at and see if the projected cost savings for the year for patients, specifically because of that increased reduction in insulin for the IER group. So there were savings for the participant, projected cost savings per year were $70 for the participant and $260 for the government. And then if you look at the IER group specifically for people who are insulin controlled, there was a significantly greater reduction in cost over the year. So considering that over 250,000 people with type 2 diabetes are insulin controlled in Australia, this could be quite a significant cost reduction for the government. So weight loss, here we can see very similar results to what we saw with hemoglobin A1C. Weight decreased significantly over time, but there was no difference between the treatment groups. Approximately 6 kilo reduction in both groups, and that represented a 6% weight loss. We used DEXA to measure body composition for our participants, and all measures of body composition also decreased significantly over time. Common questions are, what about lean mass? And so lean mass reductions, the reduction was slightly greater in the IER group, but it only approached statistical significance. Participants were encouraged to increase their steps by 2,000 from baseline. We wanted to go with a slightly smaller recommendation as opposed to the standard 10,000 steps, just to make it a very consistent change for all of our participants. So steps increased nicely over time, but not by treatment. And exercise was not restricted as a result of the IER diet. Anecdotally, patients or participants told me that they had no trouble going to the gym on IER days, they had no trouble riding their bikes, going swimming. So there was really no negative effects associated with the diet and exercise. And of course, a greater percent change to steps did result in a greater weight loss, which we all know. We measured appetite via visual analog scale, so Likert scale of 1 to 10, looking at fullness, satisfaction, and appetite. And the results there, again, nothing new. Appetite decreased significantly over time, and feelings of fullness and satisfaction increased, with no difference between the groups. Therefore, I had no adverse effects, in our pilot trial, it had no adverse effects on appetite. So probably the biggest clinical question, and probably what you're all wondering about now, is what do we do with medications on these heavily restricted IER days, specifically the medications that are likely to cause hypoglycemia like sulfonylureas and insulin. So what we did is we did a review of the VLCD literature, consultation with our research team's endocrinologist and a wider group as well, and some trial and error. We published the results of what we found in a short review in World Journal of Diabetes. And this is our protocol. So if baseline hemoglobin A1C is less than 7%, then sulfonylureas and insulin were discontinued at baseline. If hemoglobin A1C was greater than 7%, then sulfonylureas and insulin were discontinued on IER days only, and long-acting insulin the night before an IER day. And if hemoglobin A1C was greater than 10%, then sulfonylureas continued, and there was just a slight reduction of insulin on IER days only. Using this protocol, less than half of our IER participants experienced unwanted glycaemic events after the first 2 weeks of treatment, and there were certainly no high-risk hypos. Approximately 1 event per person was noted. Of course, medications were altered in response to those glycaemic events, as well as weight loss later on in the trial, and that obviously reduced the risk of hypos or hypers over time. So In the IER group, it was really difficult to tell if events were due to the treatment or if they were actually a usual occurrence for the participant, because they actually occurred on IER and on non-IER days. So quite often, hypos were occurring due to irregular eating, and hypers were occurring due to extra discretionary food choices or poor dietary compliance. In the CER group, hypos were less likely because we didn't change medications in that group until weight loss was achieved and medications were only removed at that time. But we did see hypers, and that was usually due to poor dietary compliance. So what about 12 months? 49 of our participants have finished to 12 months to date, and we're expecting another 46 participants to finish by the end of the year. Unfortunately, compliance after 3 months of treatment was an issue for both groups, and so what we saw was a maintenance of results from the 3 months to the 12 months, still a significant loss or reduction from baseline. Very important to note that that this is only preliminary data and not all of our participants have finished to 12 months as yet, so I'm just showing you some completers data to add some interest to the talk. So here you can see hemoglobin A1C reduction was maintained at 12 months, and that was a significant loss from baseline. So it was just a little 0.1% increase, but exactly the same in both groups. The decrease to medication was maintained over this time, so there was no further, medications didn't need to increase as a result of poorer compliance. Weight loss was also maintained at the 12-month point, which is a significant loss from baseline, and it's about a 7 kilo loss in the CER group and a 6 kilo loss in the IER group, still very similar in both groups. And body composition remained the same, no difference between groups. So this preliminary data suggests that a 2-day IER is comparable to CER with similar improvements to glycemic control and weight loss. The need for medications are reduced and the cost burden as well for both the participant and for the government. So the study is ongoing with a further 46 participants due to complete to 12 months by the end of this year. Because during our trial it was quite difficult to tell if the unwanted glycemic events were due to treatment or if they were a usual occurrence for the individual, we've decided to run a short acute trial, which I just started last month, using continuous glucose monitoring. So you can see the continuous glucose monitor or the sensor in the arm there. Basically, we're using that to monitor what happens during the participant's usual diet for a fortnight and then monitor what happens during the IER treatment, and that will give us some good, will give us lots of data according to Grant, and some really useful information to modify our medication protocol in response to what we see. So I'd just like to thank very much my supervisors, Professor Peter Clifton and Associate Professor Jennifer Keogh, our research team, of course the participants involved, the Sampson Institute and the University of South Australia. Thank you very much. I'd love to have your questions.